I think we should start with the statement that ALL is a very developmental area of research. We have more and more treatment options, one of which is hematopoietic stem cell transplantation. 10, 15 years ago, the issue was rather clear. We knew that patients with high-risk disease need to be transplanted. The problem was to find a donor, because relatively few patients had HLA-matched sibling donors. Unrelated donor registries were growing, but less than half of patients could find such a donor. Now the situation is quite different. We have more effective baseline chemotherapy. We have novel immunotherapy agents like bispecific antibodies, immunoconjugates, and others. We have CAR T cells in horizon. So it may be assumed that the role of hematopoietic stem cell transplantation will be diminished. But so far it's not the truth. We have run a European survey to see the trends in the use of allogenic and autologous hematopoietic stem cell transplantation. We demonstrated that up to year 2012, the numbers of all allogenic transplants from sibling donors, from unrelated donors, haploidentical donors were growing. So the utilization of hematopoietic stem cells in acute lymphoblastic leukemia in adults with acute lymphoblastic leukemia is still very high. The inverse trend is observed for autologous transplantation. In fact, there were several studies comparing autologous transplant to conventional dose chemotherapy, and none of them showed benefits from autologous transplant. But these studies were performed before the era of routine assessment of minimal residual disease. We now know that MRD status determines outcome of regular chemotherapy, but also of autologous transplant. And there is a trend to rejuvenate autologous transplant as a treatment options for patients with acute lymphoblastic leukemia. Once again, the issue is that we should look at MRD status, and only MRD negative patients are believed to potentially benefit from autologous transplant. And second, we should optimally place this procedure in the treatment continuum. So according to my belief, autologous transplant should not be a single event that ends the treatment of adults with acute lymphoblastic leukemia, but should be preceded by consolidation and followed by maintenance therapy. Such a study evaluating the role of autologous transplant in Ph-negative ALL is currently being run in Poland by Polish Adult Leukemia Group, and there are several other study groups testing autologous transplant in Philadelphia positive acute lymphoblastic leukemia. Yeah, with regard to Philadelphia positive acute lymphoblastic leukemia, the landscape changed dramatically with the introduction of TKIs. We know that generally using TKIs, introduction of TKIs contributed to improved outcome of patients with Ph-positive ALL, but also it allowed incorporation of autologous transplant in the treatment algorithm. We have performed a study on behalf of Acute Leukemia Working Party of the EBNT, showing that in the era of TKIs, results of autologous transplant are quite comparable, if not better, than allogenic transplant, provided that the transplant is followed by TKI maintenance. The potential advantage of autologous transplant is that there is no risk of graft versus host disease, which occurs in up to 40% of patients treated with allogenic transplants. There is a hope to avoid transplant procedures generally in patients with Ph-positive ALL. And in fact, such study is currently being conducted in the USA, incorporating ponatinib with hyper-CVAD chemotherapy regimen. Those investigators believe that cure is achievable without any transplant. But this must be demonstrated, that we will wait for results of that study.